Hey, sorry for that delay in the start time. I just realized I never started the broadcast. We were talking with John from one of our panelists, and both decided that when you're away from your studio, you get a little rusty. So, hey, welcome, Happy Nurses Week. We also like to welcome everybody to Euro Nurse. We meet every Saturday at 9 a.m. Central Time, and you're joining us on YouTube, Facebook, or LinkedIn. Welcome to that too. Also, hit those like, subscribe, and share buttons. And if this is your first time joining us at Euronurse, check out our website at uronurse.com, where you can learn all about us. And it's the best place to go to see our 40 episodes that we've already posted on demand anytime you want. If you're interested in sponsoring the program, hit that sponsor info button. And of course, you're the audience who drives this now that I've turned you on and you can actually get on board with the comments. So feel free to enter a comment at any time you want. And all of the formats that we use allow for comments. So great. This week is going to be an interactive meeting. So it's the second part of my urodynamics talk. I spoke about urodynamics before. If you watched that episode, that's a good plus because it's going to be necessary. But we're going to ask you a lot of questions and try to get your input on the show. So feel free to use that comment box generously. Also, thanks to Suna, we're going to be having a drawing at the end of the meeting. So stay on till the very end. What I'm going to do is give you a keyword that you'll have to put in the comment box if you want to be part of the drawing. The drawing is for the Introduction to Urodynamics Testing Workshop offered by Suna and presented by Dr. Michael Gray. Dr. Michael Gray is a great speaker. I've heard him several times. His stuff is great. I can't say enough about him. It's the Rosemont in Illinois, so it is a kind of a Chicago-based meeting. But if you want to even fly in for it, you'll get that free cost. It's normally this is like a $250 value. So pretty nice of them to offer that. So at the end of the meeting, stick around and we're going to do a drawing. And it is totally random. So it's the machine's going to do all the work. I've never done this before, so we'll see how it goes, but it's going to be interesting to see how everything works out. At this point, I want to bring our expert panelist on board. And yeah, there we go. Hey, welcome, John.
Welcome. Yay. Welcome, everyone.
Yeah, it's really great to see everybody or get back to the real studio. And I was starting to talk at the beginning, and I could see there's a little box that shows how many people. I was just curious how many people were tuning in, and there was nobody there. And I go, I forgot to hit the button that says start broadcast. So now I see.
A lot of people don't realize how much work goes into one of these productions, and even though you've done it 40 some odd times now, it's still a production.
Yeah. At the end of the day, it's always interesting to see what goes into it, how what's involved, and like you said, we were talking about earlier, is you just tend to forget what buttons to push. So that's always something. So welcome everybody. So it's going to be Dr. Lynn and I talking today as our experts. Again, your favorite stories, general questions, comments, anything you want to put in that comment box, feel free to reach out. If you don't have anything to say, I didn't ask you, John, did you have a favorite story? You usually do.
Oh, yeah, there's always something to talk about.
All righty. I think I'm going to let you go first then. Let's see. I got to switch it over to here. There we go. So I'll let you go ahead and give your story first.
This is a guy who came in yesterday, I saw in the office, and it's a guy who had a TURP done, about several months ago. I'm following up with him to see how he's doing. And as usual, he did great flow. Symptom score significantly decreased. So I asked if he would not mind sharing his story about what happened and how he went through his entire ordeal, how he had bladder infection and he finally decided to have a TURP, and then how he's doing now. So I actually recorded this interview, and you can find it on Sunrise Urology's Facebook page. At the very end of the interview, I like to ask my patients, how has this transformed? How has undergoing this process and this procedure changed your quality of life or transformed you? And this is something that's never happened to me when I interview someone, is that he became very emotional. He teared up. You really couldn't tell too much on the camera, but he teared up because he felt so happy, so grateful that his life has improved. He is no longer tied to knowing where all the bathrooms are, their horrible urgency, frequency, weak stream, taking forever to void, sometimes having accidents and bladder infections. He no longer has that just in the several months since his procedure. So he was so grateful. He teared up at the end of the interview. So the story is that the bottom line is that, and why this is important to you, is that even though we crank through 30, 40, 50 patients a day, and you may think, oh, this is just another patient. It's important to remember that we are impacting patients' lives every single day. Even though we are simply doing our jobs, you're changing somebody's lives. Back to you, Vic.
Yeah, I agree. That's a great story, and I think it's a good reminder. Plus, I think it's a great idea they have a testimonial on your page, because patients are always looking for the ratings that people give on things, and mostly I find is you rarely see the good ones. It's always the people who have a complaint, and sometimes it's a beef about something that has nothing to do with anything, but they just like to crab because they didn't, the color of your walls was wrong for my feng shui or whatever they call it.
Yeah.
But yeah, I think that's a great idea, because that to me would have a lot of impact, and true testimonials, right?
Yes. So you always want to look for that social proof. I'm very big on marketing and also capturing these reviews and testimonials. We have close to 1,000 Google reviews for our practice.
Yeah.
That's how important it is.
Yep, absolutely. You can't avoid. I'm finding out more and more from this that you just can't avoid being part of social. So it's really important that's where people are going for it.
Definitely. And I love talking about how to respond to these negative reviews and how you can manage your online reputation.
Yeah. It might be a good, interesting talk down the line, even to kind of cover that, because it is part of our practices, like it or not. So my story comes from my recent trip to the Florida Keys. I was real nice trip. I never did it. We landed in Miami, drove all the way down to Key West, and we stayed somewhere in the middle in this key called Cujo Key. It was really a nice vacation. But one of the places we stopped was at the diving museum, and I'm a ex-scuba diver. Well, I guess you're always a scuba diver once you've done it, but I don't scuba dive anymore. But anyway, I was really interested in the history. And of course, being in urology, you find things that really jump out to you. So this kind of jumped out to me. Whoops, get my button here. Let me just get that out of the way. So this picture I saw, the urinator pictura, and it's not looking like anything for urination. So I'm wondering what the heck is going on? What's the urinator? So I did a little research when I got home and found out it's Latin for the word urinary, which means to plunge underwater. Didn't know that. So basically, somebody who's a urinator is someone who plunges underwater, or otherwise known as a diver. So kind of interesting.
No idea.
Yeah. All this time, you're a urinator, you're really a diver. So it was kind of a surprise to me too.
I was explaining to my staff, one of the patients had sugar in the urine. And I said, glycosuria, that's the name. So do you know why it's called glycosuria or sugary urine? That's because in the olden days, how people were being diagnosed with diabetes was that the urine is literally tasted. And that's how you find, oh, it's a sugary tasting urine. So you are spilling sugar in your urine. You most likely have diabetes.
Yep. I had a old time urologist when I first started, and he would pick up the urine cup, smell it, look at it. I thought he was nuts. He didn't taste it, thank God. but he would go, yeah, this is infected, run a culture on it. Well, 40 years later, I can tell you, I do a lot of eyeball urinalysis and nose urinalysis. You can tell you've done it from experience. You know what to look at. So he wasn't crazy. He was just that good.
Yes.
All right. Well, I don't see any comments coming in, so I'm ready to get rolling with the show.
No, hang on, Vic. Why don't you introduce yourself?
Oh,
who are you?
Who am I? Well, my name is Vic Senese, and I'm the host and producer of the uronurse.com. I'm also going to be the guest speaker for today, and this is my second part of the two-part series on urodynamics. So I'm really anxious to get into it. It's going to be interpreting it, and again, I say it's going to be interactive. So I've got the comments up here so I can see what's going on, what you guys have to say, and I'll just bring you guys in. John, your testimony also reflects good teamwork of your clinic as well. So that was a nice comment from Charlene for you, John. So, hey, that's what the comment box is for. Please be free to use it or use it freely. Now, I'm going to switch over to my urodynamics and let's see how this works. Hey, it worked. Interactive, I'm trying a few new tricks, so we're going to see how this goes. So bear with me, but here we go. So yes, we are going to be talking about interpreting urodynamics, the real important part of all this. And I got to push the right button. There we go. So the one thing that if you haven't watched part 1, I do recommend going to episode 39, take that deep dive. It's going to go into the nuts and bolts of doing urodynamics, which I'm not going to cover today. I'm just going to review a few things. Basically, when you're filling the bladder, the things we're looking for are the 3 C's, S&D, capacity, compliance, competence, sensations, and detrusor response. I kind of link capacity and sensations together because one of the sensations is the capacity of your bladder. So I think that those two really go together. We're going to talk about compliance, how well the bladder stretches, the importance of compliance, that as you start hitting capacity and that pressure starts going too high, it can be dangerous. We'll talk about that. I'm just going to review a couple of the normal flow rates. So for men, if you're younger, up to 22 cc's per second. As we get older, up to 13 is still acceptable as normal. Women, of course, have a higher flow rate. Children. One of the things I did find is that you can make a prediction based on low flow rates. If it's less than 10 cc's per second, 90% of the patients are obstructed. And you can see those things there. So anyway, those are a little kind of get you ready for the information. When we're looking at detrusor response, we're looking at that detrusor line. It should be nice and flat. It shouldn't go up on a strong arc. So that looks good. That's normal. When we're looking at this one here, where that arrow is, we see that big jump, that big hill. That's not what's supposed to happen during filling. Bladder should be nice and relaxed. Voiding pressure flow, the emptying side. Of course, the normal voiding pressure should be somewhere between 10 to 40 centimeters of water. That's the standard that we use to measure. So let's get right into it. Now we're going to dig deep and do some studies. So here's our first study. It's a 65-year-old male, comes to the office. He's complaining of difficulty urinating with a slow stream. We've all seen those guys before. He goes and does a pre-study uroflow and has a Qmax of 5 cc's per second and a post-void residual of 50 cc's. He voided 200. Of course, as I mentioned in our previous talk, I did a urinalysis, make sure his urine's clear. There's the result of that UA, so everything is good. And this is what we see as our result of our urodynamics. Now let's take a deeper dive into here. So as I said, we want to look at the capacity and sensation kind of as a together thing. So we'll bring those together. And really the two biggest things I'm focusing in on is this one right here. And that's our first sensation, and 100 cc's, pretty normal. That's where I would expect to see it. What about capacity? Now, this is your chance to go and put in on the comments. What do you think about a 161 cc capacity? Is that a normal capacity? Let me know what your thoughts are. I'm going to keep going along and we'll bring those up as I see them. The next thing that we look at during filling is compliance. Now, compliance is this line right here. That's the detrusor. It should be a nice straight line. Now, I know we see some bumps here on there, but that's contractions. We're overall looking at what the detrusor is doing. Is it coming down to baseline like that in between? And that's what we want to see. It should be nice and stable. So I'm good with that. Now let's go to, we're getting some information. Hey, this is working. So we are getting some information. No, definitely not normal. Yeah, I think that's low capacity. Susie, Very good. Noel says no. Low capacity. Raj says, and April, low capacity. All right. Now, what do you think the detrusor response would be here? So feel free to go ahead and fill that information in and we'll bring you up here. But in detrusor response, this is what I'm focusing on right here. What's going on there? What is that? And I did kind of mention stability was the term I like to use still. It's an older term, but I think it makes more sense to me. But go ahead and fill that stuff out. And I, of course, hit the wrong button. Okay, so here we have our first reading. So I'm going to go along with what everybody said. Again, talk about what, or if you can put information in what you thought was going on with the detrusor response. So, and let's see, I want to see if I can bring John up into this. There we go, in case John wants to comment at all. So we have a 65-year-old male, comes to the office complaining of difficulty urinating, slow stream. We talked about all that. So during his filling, I'm saying the bladder is compliant. Even though we see those bumps up there, it's staying nice and flat throughout. So it's coming back down. Normal sensation, the first sensation I think is perfectly normal at 100, with a strong urge to void at 161, consistent with decreased capacity. You guys got that one right. And not too surprising with that overactive bladder that he's not going to have a real high capacity. So his bladder, I would say, is overactive, consistent. The detrusor would be, response would be consistent with overactive bladder. And I don't see anybody taking a chance here to put that down. Don't hesitate to fill those things out. You guys get your chance to be part of the show. So, John, you agree with that?
Yes, I think when performing urodynamics, it's not just looking at the graph and looking at the numbers, correlating that with patient's history. Also, the main thing I think is what question are you trying to answer with that study? So you have to kind of start out with that question in mind at the outset of the study and then conduct a study to see if it supports or goes against your hypothesis.
Yeah, good point. All right. Now, keep it going. Let's take a
when
closer.
you're looking at the detrusor curve, you also notice that it's coming from vesicle, the transducer, and the bladder. So it's truly coming from the bladder and not from
the abdomen. Yeah, good point. All right, so now I'm looking at our voiding part. And again, this is nicely marked. I liked how this shows here where detrusor at Q max, that was 105 centimeters, and Q max is the max flow. It's kind of maybe a little hard to see, but that's that flow rate that's showing there. So the max flow was 6 cc's per second. And so what is your diagnosis, folks? What do you think when we see 105 centimeter? Remember, 10 to 40 is normal, and a flow rate of 6 cc's, up to like 12 cc's per second is normal. So go ahead and put in your comments, and I'm going to go and discuss those things. I do know there's like about a 5 or 6 second delay. So I know that as I say things, you guys are hearing it and responding. So I do see a little delay, but again, please go ahead and put in what you think is going on here. What's the diagnosis? As John had said, what are we looking to prove on this guy? And mostly we're trying to see, is he obstructed? So I'm going to go ahead and switch over my screen here. So yeah, so down here, we say that my final diagnosis is his bladder was contracting, overactive. There's too many buttons to push. Here we go. So during the voiding, the patient had an elevated voiding pressure of 105 centimeters with a decreased flow rate of 6 cc's per second and a post-void residual of 55 cc's. So I would say this study is consistent with bladder outlet obstruction. I always like to just call it bladder outlet obstruction, mostly because, it doesn't necessarily have to be prostate. Probably most men it's going to be prostate, but think about a urethral stricture. That's still a bladder outlet obstruction that would have the same same elements shown on the urodynamics. And I do see Nancy came in here with obstructed flow. Hey, nice job. And I see some other ones coming in here. Bladder outlet obstruction, small capacity. Thanks, Shilpa. And see anybody else coming in. All right. Great. So you guys are on the dot with this one. All right. So let's go to our next study. A 55-year-old female comes to the office complaining of frequent urination. Patient voided 200 cc's with a pre-study uroflow of 25 cc's per second and a post-void residual of 10 cc's. And of course, got a urinalysis. And what do we notice on the UA? So big time, nitrite positive, leukocyte large. That's evidence of urinary tract infection. I would also probably look under the scope to see if there's bacteria. But this would be a patient, as we mentioned in the prior study, that we would not go ahead and just do the urodynamics because her frequency could just be a urinary tract infection. So I think it makes sense to go ahead and look at and treat the urine for infection before we do anything. But we're going to go ahead and treat her, have her come back to the office. Her urine is now nice and clear. And we're going to bring up the study. This is what the study looks like. So again, we want to look at all these things that we talked about before. The first urge at 300, strong desires at 375, and capacities at 500. Audience, what do you think about the first sensation at 300? Any thoughts on, is that early sensation, normal sensation? Give us your thoughts. The next thing I want to look at, again, is, so these things here, those little lines, that was pre-study. That was the cough to check to make sure it's working. But we want to make sure that this line is not going up too fast, less than 10 over the course of the entire study. So I'm happy with that. That looks good. So we have a nice compliant bladder. Detrusor stability. I don't see any bumps here. I see that these little things that we see in here are artifacts. We get those all the time. We're seeing them in both channels, as John had pointed out earlier. If it's in the abdomen and the vesicle, the detrusor, the machine takes it out. So we see a nice smooth there. So let's see. We do have some comments coming in here. I'm going to bring these up. Deborah said, normal sensation, I would think. Okay. Shalipa at 300, normal tends to hold. Normal could be around 200, Susie. So I'm good with all of those comments. My thought is, it's not even though we tend to see first sensations earlier, around 150 to 200, 300 is not that unusual. Again, remember, this is a testing situation too. What happens at home and what happens in the office may not always be 100% in sync. So I'm really pretty good with that. Now, this is the voiding study. So this is the one I'm going to really have you guys give me some information on. So this is our voiding curve right here. We see a nice normal looking voiding curve. I threw the scale into the side. So we're voiding pressure 24 is somewhere between 24 and 30 probably cc's per second. Now here's our two channels and here's our detrusor. So my question to everybody is, what happened here? What's this pressure? And go ahead and please fill that in. As we're coming to that, Nancy said her capacity is 500, so 300 I think is a bit delayed. But what is void? Yeah, so now we're getting to that. So good comments here. So we're going to switch the screens if I can. Do that. So folks, go ahead and put in what was that missing part. I'm going to read off what I found, or the way I would say. Her filling. During the filling, the bladder was compliant and had a first sensation at 300, strong desire at 375, and a strong urge to void at 500, consistent with delayed sensation, maybe, but otherwise normal sensations and capacity. So normal capacity. During the voiding, and here's the answer. So I'm waiting for some of you guys to put it in, but during the voiding, patient had no voiding pressure due to the sensor falling out. Normal flow rate of 25 cc's per second and a post void of 50 cc's. Shani, You got it. Sensor wasn't removed. The patient voided it out. So not too uncommon. We see that periodically. The patient will just void out the sensor. Of course, I would redo the study and put the sensor back, replace a new sensor in there to get that information, especially if I was concerned about the patients. I really needed the voiding pressure because it could be important if I was assessing for BPH, especially. I'd want to know that. But absolutely, that's just no sensor. So tricks a few people up sometimes, not everybody. So just see if anybody else got it. Nope, no more comments on that. Let me get your comment out of here.
The giveaway is that the vesical pressure sensor is not reading anything.
Yep. Good. Didn't fool you, huh, John? Let me see here. So next study, 65-year-old female comes to office with urinary frequency. By the way, I know I did give a talk on the use of Midjourney. All these photos I produced myself. I did it in Midjourney. So it is a fun toy to play with, almost dangerous sometimes. Susie said it was a trick question. You're right. It was a trick. And that's why I put it out there. So 65-year-old female comes to the office, urinary frequency. And this is what her urodynamics looks like. Now, I'm going to ask you guys what all those lines are. Are those hyperactive events? Is she coughing? What do we see with all those spikes? And I am going to switch over here where I can bring this up. So these are, just so you know what I'm talking about, these things here. And we see them throughout the study. It's not necessarily a trick question. So I do want to see if anybody can give us their thoughts on what they think's going on here. So I'm giving it just a few minutes here to come up there. But throughout this study, we see this spike. We see this spike. We see this spike. John, you got any thoughts?
It looks like an artifact of some sort. And you see the concurrent increase correlating between the abdominal sensor and also the vesical sensor.
Yep.
But if you look at the detrusor, it's very nice and quiet.
Right. Yep, definitely. So, all right. Now I'm starting to get some answers here. Susie says could be bladder spasms. Now, Susie, a bladder spasm would look like this.
It's more of a gradual curve that you see if it's a bladder spasm.
So this nice guess. Nice guess. There is no bad answers. Again, we're seeing some bladder spasms. Can I give a? Oh, yeah. Nancy went and heard me speak about this, and she knows the answer. So yes, this actually. So some people would think maybe this is a cough, but I can tell you that a cough would be more like this. Boy, by terrible drawing. More like a tent, a little spike. This was the patient who had hiccups throughout the study. The hiccups are very short, so you see them. They're in both channels. As John said, it's an artifact, definitely an artifact. And that's what hiccups look like when you're trying to do a urodynamic study on somebody with hiccups. Interesting. And then one thing I always say is that's fun about doing urodynamics is you're always going to be surprised. Now, if you give this to the doctor and they have no idea, so they're not at the study and they're looking at this, that's going to be a very hard study to read because you don't know. Now, if you're standing there doing the urodynamics and you see the patient having hiccups, it's a dead giveaway. So that's why I did trick you guys. So hiccups make sense. Great slide. Yeah, thanks. I was glad to find that one. I'm going to, I guess, I wanted to talk about this too. So right here, now the machine, a lot of these urodynamic machines mark out what the highest pressures are. And that's not really the right reading for this voiding pressure. You want to read the peak pressure the pressure at the peak speed, the velocity. So at 17 mils per second is the highest level. This is where we should be reading that study right there, not at the 54. So this is a flow rate of 17 and a pressure of 25. This is a normal study. We got a nice compliant bladder. First sensation 172. The final sensation was at 519. Somewhere in the middle there was probably a strong sensation that they didn't mark. Voiding, normal pressure, normal flow rate, normal study. So that to here. So, and that's basically what I came up with during this. I don't think I put down the patient had hiccups in here. But anyway, during the study, 27 centimeter flow rate with 17 cc's per second. Pressure with 17 cc's per second flow rate. Normal study. Get rid of that comment here. Now we're going to go to our next slide.
Hey, Vic.
Yeah, go ahead.
Answer Nancy's question.
Oh, I just saw that pop. Did patient leak with hiccups? That's a good. I know they didn't leak because the flow rate's 0. So we see this. If we look here at the flow during all these little hiccups, no leak. So we sort of have a stress test if you were interested, because these hiccups are hitting 100 right here. That's pretty decent stress with no leak. So good question. Thanks for seeing that one, John. All right, our next patient is a 65-year-old male, comes to the office in urinary retention. Get enough of those guys, don't we? Want to communicate. So here's what his study looks like. So comes in urinary retention. We are filling his bladder. He does have a first sensation at 246. Then we're in the middle, strong sensation about 296, and a capacity of 356. Again, we look at the compliance with our detrusor pressure. Nice and good. This right here is where we started. Patient was cued to void. So from this side down is filling. From this side over is voiding. And we look at the voiding, and we do see there is the detrusor squeezing here. And it goes as high as 17 centimeters of pressure. And down here is our flow rate, and it's 0. There is no flow. So what do you think's going on with this guy? I'm going to put this out to you guys. Put your comments in. Patient has, I would give away his normal sensation. So he is feeling his bladder fill. It does squeeze. There's no flow. And he came in with urinary retention. So you know the history. You know the urodynamics. What is the answer? What is his diagnosis? What are we seeing here? Waiting for some comments. Come on.
Vic, I'm kind of surprised that there's no reading from the abdominal transducer as he is doing what he's trying to do.
Oh, well, if he was straining, you would see it in the abdominal, right? So here's our abdomen right here.
Correct.
It's nice and flat. So we know we know this is true vesicle.
Yes.
So that's a good point that you have for us here, John. So let's bring this into so as we mentioned, he comes in with urinary retention. So we say what his sensations are. 246, we could call it consistent with a delayed sensation. I would think that's reasonable. And I do have some answers coming in. April says, hey, does he have a stricture? I don't know, April. I think a stricture, as we mentioned before, would have the same urodynamic as an obstructed bladder from a prostate. High pressure, low flow. Strictures, high pressure, low flow. Susie says, how about obstruction? Maybe. I can tell you that we can't tell from this study whether it's obstructed or not, because high pressure, low flow. We're not seeing that. Urinary retention, Raj definitely does. We know the patient has urinary retention. That was the history. And he retained all the urine from the study. So the study really confirms that. So I like that. Issues with incontinence prior, overflow incontinence. I didn't really give that away in the history, so I don't know if that's pertinent to what we're trying to get. So what I'm really pushing here, what I'm looking for is what's the definition of a low pressure, low flow, or low pressure, no flow study. And that's consistent with a hypotonic bladder. So this is a weak bladder. So this is a guy that comes into the office and says, I can't pee, and you're thinking to make him feel like that patient who gave the great testimonial, who had the operation, the TUR, and now he's peeing great. This patient may not write that great review if you do the terp on him. Right, John?
That is correct. And this is one of the perils of guys waiting and waiting and waiting, even though we're fixated on the prostate. What I'm really worried about is the bladder. And this is the way I describe it to patients when they first come into the office. Prostate, I don't care about the prostate. Prostate's a liability. I worry about the bladder. When you reach this point where the bladder no longer has the ability to squeeze, you're kind of hosed. In this situation, barring any other neurologic issues, this is a bladder that no longer is able to squeeze. So unfortunately, this gentleman, I tell these guys when they first come in, once the bladder gives out, then you have to self-catheterize, or you're relegated to an indwelling catheter. Is that the kind of life that you want to live for the rest of your life? So
yeah. Good point. I mean, and being in urology as many years as I have, I could tell you that I check my own post-void residual just to make sure it's never growing up too quickly. And that's the importance of seeing a urologist, to come in for those regular routine studies, because we've all had those patients. They come in there and they've got, 2-3 liters of urine in their bladder. You do the urodynamics and this is what you see. And it's just a sad situation. They waited too long.
And the worst cases are, thankfully, they're very rare. The worst cases are these guys come in from the ER, and they come in with their labs, they come in with the catheter and acute retention. Here, help me, doc. And then you see that their creatinine has already risen up to 4 or 5. They're on the way to renal failure and possibly dialysis.
Yeah.
Avoidable things.
Right. And Susie says 65 is kind of young for that diagnosis. I don't know. I've seen plenty of them in my career. I agree, typically older, but not always. And we've had some patients, in their late 50s that have had significant obstruction. So it varies. I always say
40s.
It's kind of like shoe size, nose size. Everybody's, built different. Genetics has a lot to do with it, I think. So here's our next patient, 45-year-old, come to the office complaining of difficulty urinating. Post-void, patient voided 200, pre-flow at 25 cc's per second. Post-void residual is 10 cc's. Let's take a look at his urodynamics. Here we go. So we look at all the sensations. They're kind of weird here in their area, but 76 was his first sensation, 206, 231. I'm pretty good with all those. It looks like pretty normal sensations to me. Here's our detrusor through filling. Looks nice and flat and stable to me. I'm happy with that. It's not going up too far, so I know this is a good compliant bladder, so I'm happy with that. So I would call the first part of his study normal filling. Now let's go to a blow up of our voiding study. So here's his voiding study. He has a pressure of 30 centimeters between the 10 to 40, so it's in the normal zone, and a flow rate of 21 cc's per second. So looks normal to me. Anybody want to argue with that? Go ahead, fill it in the comments if you think there's another reason that it wouldn't be normal. I'd be happy to hear your opinions. But so, does anybody have any ideas what's going on here? What's his problem? He came in, he complained of something. Normal study, as far as I'm concerned. All the figures are pretty normal. Anybody can throw out some ideas of what's going on here? I'm going to throw some at you and see what your thoughts are, and why I think some of these are possible. Could he have an overactive bladder? Anybody out there think he has it? Go ahead, put it through on the comments. I think he could possibly have it. One of the faults of a urodynamic study is it's a single shot, like a camera taking a picture. And if the tree didn't fall while you took the picture, did the tree not fall? So possibly you did a test that you got lucky enough and he had no overactive events during it. So it's possibly could have overactive bladder. Any behavioral thoughts? Anybody got thoughts about why this? Come on, folks. I know I got an intelligent audience out there. Let's see some thoughts here. Think about it. Behavioral things that could cause this. Anybody got any ideas? And John, feel free to chirp in if you've got any ideas. So I could come up with some behavioral things. I got these. If you do the 3-day voiding diary, sometimes you find out some really interesting thing about people. So, I like it. Here we've got somebody thinking that's just what I'm going to talk about. Maybe he drinks too many bladder irritants, caffeine. Absolutely. Could be a behavioral issue. Could be somebody who drinks, everybody's telling them that, drink more water, drink more water. Well, some people take this really to heart and they drink a whole lot of water and they don't understand that they're going to drink, urinate more frequently from drinking a lot of water. So it can be a behavioral thing, bladder irritants, definitely. What about testing artifacts? Anything that would be somebody would call artifact? I don't really know that I would say that there's anything on the test that looks like it's just a problem with the test itself. Sometimes patients have problems performing during the test, but that wouldn't have shown up on this, so I don't see that. I do have Ann coming in. Hey, I'd like to say thanks to all you guys with all your comments. You're really being a big part of the show here. Behavioral daily fluid intake. Great. All good answers. And then the last thing that I'm sure John has come across these patients. I've come across these patients. I just call them BSC. I'm just waiting for some of these others to come in here. On a diuretic. Good thought. That's one I didn't even put in there. But yeah, patient could be on a diuretic. He's just making a lot of urine. Nobody ever explained to him, hey, when we put you on this medication, you're going to pee a lot. That's what it's supposed to do. So Raj, thanks for that one. So anybody got any ideas what BSC is? I don't think you guys are going to get that one because I think I made it up myself, but I just call it batshit crazy. Some people are just coming in with ideas and they don't know what's going on and they're just complaining. So it happens.
I do have patients who, and I sometimes see an association between those. I see a lot of patients who are an engineering type, very type A personalities, and they may have, I explain it to these guys this way. Some people take their stress in their shoulder, some people take it in their lower back, and some patients take it down in the pelvic area. So when you have these strong pelvic contractions and urges, it can translate to some of the sensations that you feel in the bladder, and that can lead you to complain the way you do. And there are folks who are their symptoms, their voiding symptoms may be psychogenic, but yeah, you always want to make sure that you rule out anything that's organic. And even if it's psychogenic, it may be behavioral. So sometimes referring these men to pelvic floor physical therapists may help them with their symptoms.
Yeah. That's a good point. It's one of the things I really, whenever you do anything like this talk that we're doing, you never know what you're going to come out of it with, more information. I think it's just a great idea to have this open discussion because there are a lot of ideas. Urodynamics is a thinking person's study, and it's really makes you think through these things. So I love it. I love the responses I'm getting from the audience too. And John, some of the good thoughts you've had. All right, next one. 53-year-old female comes to the office with urinary incontinence. Remember, we look at the Valsalva leak point pressure when we're diagnosing incontinence. Just a reminder of what those numbers are. Under 60, we worry about intrinsic sphincter dysfunction. 60 to 90 is kind of in the middle, and over 90 is urethral hypermobility, generally speaking. And those curves that we see there, those are Valsalvas, where you're squeezing the abdomen, and that's if you look at the prior talk, it'll talk more about how to do those. I call it the eyeball urodynamic because you're watching for the leak. And what we see here is we did this test, and her leak point occurred at 100. They replicated it several times to be sure. And 100 centimeters, she leaks. So that would put her, I'll bring that reminder up there with the number that kind of would go along with this this urethral hypermobility. So she does definitely have what you'd call stress leakage. So 53-year-old female comes to the office and has a Valsalva leak point pressure of 100 centimeters. consistent with stress urinary incontinence. That's pretty straightforward. Now, of course, I didn't go through all the other parts of the urodynamics, but everything else looked normal. Some patients could have stress urinary incontinence and could have a hyperactive bladder, an overactive bladder. So you can have a combination of both. And it's good to know that, especially if you're the doc who's going to be treating the stress incontinence by an operation, that you let the patient know that, hey, the operation is going to fix one problem, but not the other. I just got
it's also important to counsel these patients that if they have pure stress incontinence by history and also by urodynamics, that you can induce a de novo overactive bladder-like symptoms, urgent incontinence, urgency, frequency, after a sling procedure, after some sort of an operation to fix that stress incontinence. When it comes to incontinence, getting a history is supremely important. Supremely important.
Absolutely. And I think that the urodynamics can sometimes give you some information. I'd spoken, I didn't have it in here, but of a patient with prolapse, and did the urodynamics, the stress test before with the prolapse, and then reducing the prolapse physically and doing the stress test again. And sometimes you can have an unmasking when you fix the prolapse of stress incontinence. So things that are important to look at.
And for this 53-year-old female, you always have to think perimenopause or postmenopause symptoms, and also the decrease or lack of estrogen in her body, which can also affect her, not just her vulva, but also her bladder relative to urinary symptoms. We're doing such a disservice because the Women's Health Initiative study that the media hyped all the bad things that came out of it. But in actuality, topical estrogen should be liberally prescribed to women, postmenopausal women, because it helps a lot with their urinary symptoms and also with their vulvar health.
Absolutely. Yeah, no, it's as we're speaking, I'm like, that's another topic I need to get a speaker for on the use of estrogen in postmenopausal women for urinary symptoms. That'd be a great one. All right. And I think might be our last one here. 39-year-old male patient, 31 days after spinal cord injury, T8, American Spinal Cord Injury Association impairment scale. And I say, any concerns? And then the blood pressure, the guy checking his blood pressure doesn't kind of ring any bells. Please don't do urodynamics on this guy. And also, I put a little plug in for Andrea Strong's talk on episode 17 on autonomic dysreflexia. These guys, you have to be careful. If you don't know the signs and symptoms of autonomic dysreflexia and what treatments need to be done, and my prior study, I went into a little deeper dive on it, so I'm not going to do it here. But just needless to say, it's very important that you treat these guys carefully, because you can put their health at risk. So let's go take a look at this urodynamic study here. And this is what this one looks like. And the biggest thing, I put it in red, that I'm worried about with the patient is compliance of the bladder. And that's this thing going up here. So as I spoke about earlier in the prior study, is that compliance number is very important, because if the resting pressure, the true resting pressure, is greater than 40, there is imminent risk of upper tract disease. And actually, this was a video urodynamics that was done. And this is what the video looks like. And there we can see right there's a refluxing, right? For those that can't see it, there's reflux into the kidney. So this patient is definitely putting their kidneys at risk and at danger. And let's go switch over here. So the diagnosis on this patient, video urodynamics in a 39-year-old male, 31 days after spinal cord injury, showing detrusor overactivity with high storage pressure and vesico-ureteral renal reflux, jeopardizing the upper urinary tract. So that is the danger zone that we run into. So definitely somebody you got to be careful.
Vic, Nancy and Susie and Rajesh made some comments there.
Yeah, I just saw that. Thanks. Check blood pressure every 5 minutes. Yeah. Question about retention. Nancy, I love estrase cream. Yeah.
Now,
It's
keep in mind, Nancy, S-rays, depending on your insurance coverage, may be costly, and there are cheaper alternatives. Like, I have no financial relationship with Mark Cuban's pharmacy, but if you have your physician prescribed directly to the pharmacy, you may get a nice discount. And certainly look around. Also, no financial relationship with goodrx.com. Goodrx.com. I freely tell my patients that always shop around for the drug prices.
Yeah, as somebody who recently switched over to Medicare, I can tell you that that's a big thing, is looking around for drug prices. It's amazing, and I've done a lot of mine through the Amazon pharmacy because some of their prices are better. But GoodRx is a great one to consider too. So let's see here. I think that we're at the end of our talk. Couple things here. I'm just going to get ready because we do have the drawing. But please, if you have any questions, feel free to enter those questions into the comments. I'll be glad to answer them. I think we've answered a lot of them as we've gone along here, so it's kind of made it nice. Again, maybe in your comments, just put down how you like the interactive aspect. We've had a lot of, kind of lecture type talks with the ability to ask questions at the end, but the interactive, being able to, kind of throw your answers into it, what your thoughts are on that, I'd be interested, because again, you guys are steering the show. I may be running it, but you guys are steering it. What things you want to know about, what you think about, I'm always real happy to move the show in that direction. So we did get a couple coming in here. Susie said it was great. Thank you, Susie. Raj says, does laboratory data transfer to, I think it's laboratory data transfer to Epic. I don't know. I don't think so, because we have a laboratory machine. Oh, we don't have Epic. That's what it's. That's what I'm saying. There's some reason I don't know why it doesn't go to our EMR. So I don't know about Epic. So that's if somebody out there has Epic and does urodynamics, that would be great to let us know. All right. So I don't run out of time on this. I am going to put a plug in for next week's talk. Be sure to join us next week, May 20th, 9 a.m. Central Time. We're going to be having the Dr. Jason Alter is going to be talking to us about exosome from Exosome Diagnostics on advances in early prostate cancer detection and risk assessment. So be sure to join us next week. Again, if you don't get enough of us here in the original talk, go to uronurse.com and hit that after party. We'll be opening up the after party today. So I'll be glad to talk to anybody after the show if you want. And now let's get on with the drawing. So
April has a comment. And Deborah.
Oh yeah, let's get those. But and before I'll bring those up in a moment. Before I do, because I want to get these comments going, you need to put hashtag Uronurse into the comments if you want to be part of the drawing for the free Urodynamics being offered by Suna. $250 value, June 16th. With Dr. Michael Gray. And I do have to start something. This is my first time to ever do this thing, so I've got to hit some buttons so it starts tabulating. So
for the for the audience watching, hashtag Uronurse in the comment section to enter for this free Urodynamics course held in Chicago. That's going to be held in Chicago in June.
So I do have some things while we're waiting for the comments to come in. Laboratory is working on Epic. So Nancy, thanks for that. I'm glad to know. April, this was great, Vic. Urodynamics is one of my least favorite procedures to do due to lack of understanding the readings. This was extremely helpful. Great. That's really what I was trying to aim for, is to try to make this easy to do. It's, when I first started out, I can tell you that it was pretty difficult. I went to a lot of coursework to kind of get the feel for what's necessary to do a good study. But when you do, it makes a big difference for these people. Deborah, thanks for your comment. Love the learning aspect to guess what the studies show. Studying this to hopefully pass my urological RN certification soon. Good luck on that. I passed it twice. I think I told that story before. Thank you so much for this. And I do see some Uronurse. Oh, we got some people coming in here. All right. So hang on one second here. I'm going to try to bring this
Enter hashtag Euronurse in the comments for this free drawing for a Urodynamics course in Chicago in June. Hashtag Euronurse.
Here's how it works, folks. As you enter, I see entries still coming in, so I'm waiting till that settles down. So it's the hashtag Euronurse, and it's showing that 10 people have entered. When I hit the button that says draw, it's going to draw a winner. So I'm waiting to see.
Wonderful, wonderful, wonderful.
A lot of firsts in this particular episode. We got the first time I ever gave a drawing away. First time to do the interaction like this. So I think we're pretty well set. So I'm gonna pretend drum roll, please. Oh, John, you probably got a drum roll built into your equipment, right?
No, I don't think I have drum roll.
No
but
drum roll.
I do have.
There we go. So here it is, folks. And the winner.
I love this.
Nancy, you are the winner.
Congratulations.
So, hey, congratulations, Nancy. You won that free admission for the Urodynamics. Just send email me with your information at vic@uronurse.com so that I can forward it to the head of SUNA, who said they'll take care of everything. So really cool. With that, unless there's any other questions, getting some comments. Oh, let's see here. I do want to let everybody. Neil says, congrats, Nancy. Happy thoughts. Awesome. April, congratulations. Wow, awesome. Congratulations. So great things. Great comments. Well, folks, with that, I'm going to move over to the. Nancy said, wow, that was super exciting. Yeah, Nancy, I thought that was kind of exciting. It worked. That made me excited. You know, you can test this stuff at home and it seems like it's going to work, but until you're, really taking it, and you're welcome, Nancy. Until you really take it out and try it, it's always a good question on how to do this. And it's weird. They explain how to do it, but not 100%. So anyway, another great episode. Appreciate it, everybody. Thanks, John, for all your help.
You're welcome. Well, I think that this is a testament to your preparation and your technical expertise to pull this off. You're always innovating. You're always trying to make this program better, and we really appreciate that.
Yeah, thanks, John. It's fun. I've always, that's why I love technology, because I just don't want to settle with good enough when there can be something better. So I'm always looking for new ways to do things. So good. All right. Hopefully we'll see some of you guys over in the after party. Otherwise, I'm going to be ditching out of it pretty soon because today's Launch the Boat Day and I want to get my boat in the water. So we'll see everybody next week.
Bye-bye, everyone.